Ehud Assia, who again is one of the most renowned surgeons internationally, and we've been seeing amazing stuff from him. And today he's going to talk to us about initial clinical experience with the second generation of the capsular anchor. It looks really amazing, and let's see how it goes.
Well, thank you very much, and greetings from Israel. And, thank you, Gaurav and Ashwin, for the invitation to participate in this very interesting, excellent symposium. And I would like to share with you our clinical experience, initial clinical experience with the second generation of the capsular anchor. These are my disclosures, and the first one is the one which is relevant. Now, the capsular anchor, we designed this capsular clip about 16 years ago, and this was designed to reposition a subluxated lens. We started with fixation of a crystalline lens, but we also showed and presented that we can reposition also subluxated posterior chamber lens, which were malpositioned many years after the initial implantation. So here's an example of the first generation. We can see a patient with a traumatic cataract on the left, and then after reposition and centration of the lens with the anchor on the right. And we have tens of such cases, and it works really very nicely and very effective. And in eyes with very large zonal dehiscence, one can use 2 and potentially even 3 of the anchors. And this is an example of an eye with a posterior chamber lens, which was subluxated and after reposition with 1 and 2 anchors. But this first generation anchors, we saw that it was kind of a bulky device. It was thick and wide and not very flexible. And because it is uniplanar, it was also not very easy to manipulate. So now we designed the second generation of the anchor. And as one can see here, the main change is this is now 3-dimensional. It is in 2 planes. So here, as we compare it to the first generation on the left, we can see it is much thinner, it is more flexible, there is more space for the capsule to go in, but the main change is here, as we can see, it is 3-dimensional and biplanar. So here are the results of the first 10 cases, and we have the patients with crystalline subluxation, crystalline lens, in 8 patients and 2 with subluxation of posterior chamber lenses. The main reason was trauma and pseudoexfoliation, also Marfan and eye myopia. So this is what it looks like first in the laboratory, and we tested it on the pig eyes. We can see that it is now on 2 levels, 2 planes. And this is in a pig eye. We insert it, it goes quite easily, so 2.5 millimeters, and then we just place it on top of the capsule and push a little bit backwards and forward. And if we bring together the 2 lateral prongs, then we can insert it even to a 1.5 and even less small incision. So this is the first clinical case. This is a patient after trauma. The lens is quite soft, and we prefer to fixate it today with a ProLens 6.0 with flanges, with the thread, the suture through the hole at the base of the anchor, create a large flange so it would not go in. Then we put in the anchor, and then as we saw before, we just place it on top of the capsule and push it forward. And note that we did it in this case before removal of the lens material. So it also actually stabilized the lens for the surgery. Now we made a temporary flange, and the lens is stable. We see how it actually occupies a whole segment of the anterior capsule. Phacoemulsification was performed, then followed by implantation of an intraocular lens. And then after the lens is in place, we finalize the adjustment of the length of the suture, create a small flange, make sure it is in the right position. And now we finalize it, the lens is stable and central. This is what it looks 1 month post-operatively, and as we can see, the flange is well covered under the conjunctiva and the tenon. The second case is also after trauma, but it was 40 years ago, and in this case, the lens was stable enough so we could perform phacoemulsification and remove the lens material before implanting the anchor. After remove the lens, we passed the 6.0 ProLens, and then thread it through the positioning hole at the base of the anchor, create a flange, put it in, and it's quite easy to position correctly the anchor after we remove the lens and the bag is evacuated. The two lateral prongs are located behind the capsule and the central rod is in front. In this case, the patient also had a fixed dilated pupil, so we pulled centrally the iris and did a small pupilloplasty. And this is what our patient looked at the end of the operation. Note that the anchor is secured only by one suture only. This is what the patient looks like at 1 month, and with retroillumination, we can see the position of the anchor. It is actually supported by the capsular axis and the lens equator, and it occupies the whole segment, so it provides a very stable fixation. And this is the patient we subluxated intraocular lens. First, we open up a small pocket superiorly, put in the first anchor, make sure that it is in place with the two lateral prongs behind the capsule, central part is in front. And now we pull it up so we can create a second pocket inferiorly and put in the second anchor, making sure that it is in the correct position. And then finalize and adjust the tension, and we can make sure that these two anchors are located indeed in place. And this is what it looks at the end of this operation. So these are the results of the first 10 patients, and as we can see on the right, 7 out of the 10 patients had the final visual acuity of 20/25 and better, and all of them improved significantly in vision. So here's another case of inferior subluxated crystalline lens, and this is at the end of surgery, 1 month post-operatively. The IOL is well placed and central, and in this case, we can see on this oblique view, we can see how this anchor supports the capsular axis, the equator, and the whole segment of the anterior capsule. So the bottom line, this capsular support is effective as a capsule stabilizer for both crystalline lens subluxation and IOL dislocation. This modification, the second generation of the anchor, provides very significant progress and an improvement in safety and efficacy, and mainly in the simplicity of utilizing this device. And I thank you very much for your very kind attention, and really it's time that we meet again in person. Unfortunately, COVID is still here together. Thank you.